don't have optimal responses to therapy. Now therapy's been, it's dramatically changed. When I first started seeing patients with HIV back in 1983, we had absolutely nothing to treat them with. And when we started our clinic, we used to keep a little log book, and we put the names in, and when the patient expired, we'd go back and highlight them out. And way back when we started, we used to go back 6 months, half the page would be whited out. We'd go back a year, about 3/4 of it. So everyone was dying back in those days. And as of 1994, not that long ago, we only had 4 drugs that were available. Now we have 25 different drugs in 6 different classes, different mechanisms of action. We have combination drugs, so it's easier for patients to take combination regimens. And the pipeline hasn't ended. We had 2 new agents approved in 2007 and another one just this year. It's becoming a little bit more complicated to treat some of the patients, and if you looked at PubMed in 2007, there were over 6,000 articles for just how to treat HIV. Not the immune pathogenesis, not the virology, just how to treat it. And so it's really getting difficult to keep up. But the outcomes have been better. There's been a dramatic decrease in morbidity and mortality. Is it absolutely effective? It isn't. And effectiveness is reduced by resistance and by non-compliance with the regimens. So this is what we have available. It's just astounding, the number of drugs that are available these days. And the medications are not just potent, they're simpler to take, safer than they used to be when we first started out. And what are the success rates? In clinical trials, we've now seen some trials where patients can completely suppress viral replication. This is a real busy slide, but we've seen success rates up to 90% completely suppressing viral replication. And that was really unheard of just a few years ago. And the number of patients who've been failing has been decreasing over time too. The regimens are getting easier, they're more effective. Unfortunately, we do have patients who still continue to fail. Part of the reason they fail is the adherence issue. And even though it's getting simpler to take the medications, some patients aren't able to do that. How non-compliant, non-adherent do you have to be? The truth is not very bad. If you take your medications, anything less than 80%, and so 8 out of 10 doses, your chances of having the effect you want, an undetectable viral load, is really low. And I don't know about you, but whenever I've been given a prescription, I don't know if I've ever taken 8 out of 10 of everything, anything. And what about other chronic diseases? This has been looked at. In hypertension, they guesstimate that the non-compliance rate can approach 50%. The same with diabetes. The thing that's different about HIV compared to those diseases is the diabetes or high blood pressure, when you eventually start taking your medications again, they're going to work. With HIV, what happens is you select out resistance, and you can select out resistance not only for the medication you are on, but for medications you've never seen, because there's cross-resistance within some of the classes of drugs. This slide looks at the incidence of getting drug resistance mutations compared to the percent adherence. Now, if your percent adherence is 50% or less, you don't develop resistance because there's not even enough selective pressure of the drug to select out resistant mutants. But the highest rates of drug resistance are in patients who, again, are not very non-compliant, somewhere between 70 and 90% compliance. Now, what are the barriers to adherence? And again, about 20 to 30% of patients may be non-adherent. Sometimes it's medication factors. Some have to be taken with food. People can't comply with that. Some of it has to do with the dosing frequency. This has improved a lot. We are at the point where a lot of folks are on daily medication. In fact, there's one pill, a tripla. It's a triple drug combination, and you can take one pill once a day as long as there's no resistance. But for other pills, you may have to take them more frequently, take a lot of pills, and there are still some side effects with any of these medications. Then there are patient factors, so some of the things that really interfere with the ability to continue to take the medications include substance abuse, psychiatric disease. We refer to this as dual diagnosis, triple diagnosis. And it's not easy to take all these things, afford the medications. You really need a support system and a social network. And then there are problems with our healthcare system, access to care. It's very difficult for some patients to get into care. The instructions we give aren't always very good. And a lot of patients simply distrust the medical system, and that's more common in patients who are minority patients. What is some of the evidence for racial disparities in HIV care? A couple years ago, it's pretty dated now, in 1999, the National Academy of Sciences had an Institute of Medicine report on the unequal treatment confronting racial and ethnic disparities in healthcare. A huge report that not only looked at HIV, but many, many other diseases. In that particular report, they saw there was disparity of care for HIV sort of superimposed on this setting of overall poor health for minority patients. In their report, they did quote specific HIV data. 20% of African Americans who died from AIDS had a delay in diagnosis that was significantly greater from their white counterparts, even in the same geographic region. Mortality rates have consistently been higher. African Americans are less likely or less often asked to participate in clinical trials, and we see this in the United States, but it's not really seen in all countries. In Denmark, where they have a socialized form of health delivery, there's no difference, no disparity in the outcomes for HIV infection. We've looked at this in our own clinic as well. In fact, we started a study with a couple students from the Math and Science Academy out in Aurora a few years ago. Some high school students came down and helped review some of our outcomes data. They also interviewed our patients and did a very nice job. And what they wanted to see was other studies had shown that patients in a clinical practice didn't necessarily do as well as patients in published clinical trials. We wanted to look at our clinic population, see if they actually met the criteria for enrollment in a published clinical trial. This 934 study that looked at particular drug regimens that people were started on, and then see what sort of outcome our patients had. And we started this thinking our patients weren't going to perform as well. What we found was there were some big differences in the population we have in our clinic and what you see in clinical trials right off the bat. In most clinical trials for HIV, males really predominate. But in our particular clinic, 42% of the patients were women compared to 13% in the clinical trial we were comparing to. Our clinic is 97% African American, and that was the category for, that was the percent of the patients that we had started on therapy. And that was much higher than the 22% in this published clinical trial. So again, African Americans are much less likely to get into drug studies. Baseline characteristics as far as viral load were the same. So how much virus was circulating in the system, that was about the same. And the percent of patients who had a high copy level, more than 100,000 copies of virus per mil of blood, was similar. What was quite different was at the time they started therapy, what was this CD4 count? We already sort of mentioned that 200 is this break point where you started to see a lot of unusual infections. And the mean starting CD4 count for our clinic population was under that 200 cutoff. It was 175 versus 237 in the group that was in the clinical trial. If you look at it, how many were less than 200, it was 65% for our population versus 40 for the study population. And the number with really low CD4 counts, less than 50, was 29% for our clinic versus 13%. Despite that, our patients were able to achieve complete viral suppression. So I think things have really gotten easier with the treatment. Once you've diagnosed patients, you can get your patients to undetectable. And even in a minority urban population where you still have a lot of barriers to overcome, you can be successful. And when you suppress viral replication, you get pretty good immunity.